Yesterday we took the nation's temperature and found it wanting, rather on the high side. Worryingly, the previous improvements in life expectancy, we were told, have stagnated, and that past improvements for some of the what were called poorer groups have been put into reverse. And what was more, poor mental health is playing its full part in that deterioration. So that's the context in which we're having to operate. We heard yesterday in vivid terms about people's experience from some of these poorer, more vulnerable communities, and about the impact of mental health on the reality of their lives, both from the DeStress colleagues collaborating with us in Plymouth and Teignmouth, but also from colleagues who came all the way from Thanet to tell us about the work they were doing. We heard too about their experiences in dealing with GPs and primary care and indeed other services. And the pressures, of course, that GPs find themselves under at the moment. We heard in detail about the workings of the DeStress programme, developing alternative approaches to mental health through an engaged approach with local communities, and we'll be hearing more about that later on today. But what came through loud and clear, I think, yesterday was the importance of a community identity, of self-organisation in providing mutual support, and the importance of voice and the importance of patient experience in shaping such services. We heard how austerity has complicated an effective response through the impact of welfare reform and reductions in public services, and how a narrative has developed that stigmatises low-income communities, placing the blame on the individuals in those communities and not the system. We heard how any work has been placed on a pedestal, and those not working for whatever reason are excluded from consideration. We heard talk of enforced employability, where, quote, the fit note means no one is sick. Communities were urged to fight back against this hostile environment. We looked at the experience of social isolation and loneliness on lone parents engendered by poverty, and at the alarming link between poverty and the incidence of self-harm among children of poorer families. We heard from Joanna Moncrief, sceptical of current practices in mental health diagnosis and standard treatments, noting the tremendous boom in antidepressant prescribing, taking little or no account of patients' social circumstances. She had a quote as well, which she said, "With the disease model, the doctor surrenders his common sense," which I think gave us all pause for reflection. Social prescribing was seen as a possible way forward, but of course this covers a wide range of models, making it hard to judge effectiveness. We looked at how social prescribing works in some situations and the interactions between GPs and patients, and found varying approaches to this. And we found and heard about how local groups organise and provide peer support. And one of the ways they do it is by producing calendars such as this to raise funds to actually support that sort of activity. I'm sorry the Thanet folk who did this aren't here today, so they can't sell the new arrivals any more copies of this, but you're most welcome to look at my copy. And they had an inspiring quote as well. They said, "Use your hurt to promote a passion for caring," which again I thought struck a chord with the meeting yesterday. We looked too at how social prescribing was a process which links systems and released community potential. But we were asked, was this enough? We were told the inward gaze, as the phrase used, where communities and groups look at their own particular local and behavioural problems, risks actually creating widening health inequalities because of the imbalance between resources, community resources. We were told only through, quote, collective control over decisions can we rebalance this power relationship. Involvement was not enough. And that's how we finished the day. You can imagine people were still brimming over with interest and engagement and wanting to discuss this further. So we're back today to carry on some of that discussion. And we're going to start looking today at the implications for policy and practice, both in terms of some of the key issues and the views of policymakers themselves in how they approach this. This afternoon, we look at the implications for GPs and GP training and how the findings of the DeStress project can help inform alternative approaches. And at the close, we'll bring the lessons of the last 2 days together, bringing the learning and pointing directions of where we go next. So we've got a great programme of speakers, but as I reminded colleagues yesterday, a programme is only going to be as good as the quality of the debate it promotes, and we had some great discussions yesterday. So I urge you all to join in when you can, and let's continue the conversation.